regarding the COVID-19 Community Partnership Study. Just a couple of housekeeping items before we dive into questions with Dr. Sanders. If you have a question for Dr. Sanders, I'm going to ask him some initial questions, and then afterwards we're going to save some time for a Q&A. And if you have a question for Dr. Sanders, please leave it in the chat, and we'll do our best to get to as many as possible. And if we are recording this, so if you didn't catch everything or you know someone else that might benefit from viewing this, it'll be posted later on the Maya Angelou Center for Health Equity and Wake Forest Baptist website. So Dr. Sanders, thanks for joining us today for today's town hall. I appreciate you taking the time to chat with us. How are you doing, sir?
No, I'm doing great, Justin. Can you hear me okay?
I sure can, absolutely.
Yeah, thank you for hosting this, and thanks to everybody for joining us. We really want to do an even better job at communicating our results and our problems and all that's going on in the study, and we really appreciate what everybody is doing as being part of the study, and want to continue to share information. I also want to say a special thanks to all of you who wrote in to say, "Hey, John, you're live. Quit cleaning up your office." So thank you for catching me as I moved all the papers behind me on the camera.
There you go. It's a real life work environment here. Before we dive into some of the COVID study related questions, if you would just tell us a little bit about yourself, Dr. Sanders. How long have you been with Wake Forest Baptist, and maybe a little bit of background about why you decided to get into the healthcare profession in the first place?
Yeah, for those of you who don't know me, I'm John Sanders. I'm a professor of medicine here at Wake Forest and the chief of infectious diseases. I've been here for 5 years now, and my wife and I were just talking about that this weekend, that this is the longest that we've lived as adults anywhere in our lives, because prior to coming here, I was in the U.S. Navy, and we moved every 2 to 4 years. So when I retired from the Navy, we were looking for a place to teach and see patients and do research, and Wake Forest and Winston-Salem were just the perfect place to come and do that. And why I went into healthcare in the first place was that, certainly wanted to have a job where on a daily basis that I could be involved in people's lives, but also have always been very interested in all of the dynamics of infectious diseases, because it's not just about a virus, but it's about how we interact with each other, our human behaviors, and how we interact with nature.
Okay. Well, thanks for that brief intro. I do want to start off just as a level set for everyone listening. Some people might be familiar with the COVID-19 Community Partnership Study. Some people who are listening might not be as familiar. If you would just take a moment and just give us a broad overview of the study itself, what the purpose is, and what might be required of participants should they be interested in participating.
This is a research study that is designed to look at the epidemiology, or just the behavior of the epidemic, the behavior of the infection, so that we know more about where it is in our community, where we are on that curve that we've been trying to flatten. How many of us have been infected? How many of us are getting infected each month, including those of us who have symptoms and know that we've been infected, and those of us who don't have any symptoms, did not know that we were infected. Okay. And then ultimately, we want to be able to also look at what happens to us after we get infected. So it's not, it's easy for those of us who get infected and end up in the hospital. We know that that's what happened. But we don't know what happens a month later, 3 months later, 6 months later, especially for those of us who don't have many symptoms.
Gotcha. So I guess to take a step further into some details about the study, there currently are Wake Forest Baptist patients eligible, or they're the only ones eligible to participate in the study at this point? And what are some other ideas about that?
So as of today, that is true, that around here, around the Triad, Winston-Salem area, only patients who are connected to Wake Forest are able to enroll in the study. And the reason we started off that way is that we really value the data in the electronic health record. I make this joke all the time, but when President Obama mandated that we all had to use the electronic health record, I almost had a stroke because it was just so much work to get the electronic health record, to get all the medical records in the nation converted onto these computer systems. But he predicted that there would be a lot of valuable data that we would be able to share with each other and pull out of the record. And here, not even a decade later, that's exactly the case. That we really value the data that's in that electronic health record that we want to be able to pull. And so we started off saying you have to have an electronic health record with us so that we're able to get that information. But we know that there are more and more people who want to participate, who are not connected to us. And our study is spreading to Charlotte and to Raleigh and soon to other parts of the nation like New Orleans and Mississippi. And we're, as we encounter those issues, we are loosening up. So as we speak, some of our researchers are retyping the research protocol to ask permission to allow people who are not Wake Forest patients to enroll into the study.
Okay. So if, let's say I go to the website and I read some of the information or I listen to what you're telling me today, and I'm like, this sounds interesting. So to actually sign up for the study and participate, once I'm in the study, what's going to happen? What do I have to do? Is there going to be, what's the threshold? Do I have to answer a big long questionnaire every day? What you need me to come in? What's going to be required of me if I want to participate?
So the study is divided into parts. Okay. And the first part is just the syndromic surveillance. That is telling us each day how many symptoms you have and whether or not you've been in contact with anybody with COVID. And we can all take part of that. Everybody who wants to sign up can contribute really valuable data, just telling each other, do I have any symptoms and have I been in contact with each other? And then everybody who signs up, for whom we can get an electronic health record, then we can also pull the data out of the health record to look at, does it turn out that people with diabetes or people with kidney disease do better or worse? Is there an association with taking this sort of blood pressure medicine or that sort of diabetes medicine? Does that make a difference? Everybody can participate in that. And then a subset, part of the people who enroll, we send a test at home to check for antibodies, where people prick their finger and send us blood back to do an antibody test. Not everybody who signs up for the study is in that part of the test because we just can't afford it. But we are trying very hard to make sure that we have a great representation across the region, representing all ages, race, sex, gender, down to the county level, so that we really represent everybody in the antibody testing. And then we call it oversampling. We test even more people if they're in a high risk group, either high risk to get infected or maybe high risk to have a bad outcome. So we test healthcare workers, for instance, a lot more frequently.
Okay. So how's enrollment going so far? Can you give us a little bit of information about kind of the demographics of who's enrolled, and you need more people to enroll?
Well, we always need more people to enroll. Because the more of us that are participating, the more data that we have, the more we're able to share with each other. But we've had a great response from the Wake Forest community, the Triad community. We have almost 20,000 people here in this area that have signed up. And we have almost 1.5 million data points, or 1.5 million person days, where people have entered their data and said, I have a sore throat or a cough. I wore a mask yesterday. I saw somebody that had COVID yesterday. That's incredible that we've had so many people participate. And our plan is to have 10,000 of those people tested for antibodies at least 6 times this year. And so far, we've been able to enroll about 8,000 people who represent the community well demographically to be tested.
Okay. So we're testing for antibodies. Explain to me a little bit about the difference between an antibody test and a virus test. What are we looking for that's the difference?
Well, the virus is, of course, the germ that makes us sick. And most of the time when we talk about getting a COVID test, we're really talking about getting a virus test. Mm-hmm. So when the nurse puts that swab way up into your nose and it hurts your brain, or when you hear about the NBA spitting into a cup and doing a saliva test, they are looking for the virus itself, and they do it in a number of different ways, but it's looking for the virus, the genes of the virus, or the parts of the virus. An antibody is a protein that our immune system makes, our white blood cells make, to fight the virus, to protect us against the virus. And when we are talking about doing at-home antibody tests, we're talking about checking people's blood to see if they've made one of those proteins to fight the virus.
Mm-hmm. Okay, so if I am part of the study and I'm chosen to send in a blood sample, and then I get the results back that I've had a positive antibody test, what does that mean for me? Does that mean I need to call my doctor? Does it mean I'm immune to COVID-19? Talk to us a little bit about that.
That's a great loaded question, Justin. So a big part of the reason that we're doing this study is we don't know what all that means. Yeah. There are lots of questions about what it does mean. First, does it mean you've been infected with SARS-CoV-2, the virus that causes COVID, the COVID virus? It probably does. But there's always going to be some false positives and some false negatives on the test. So having the antibody is not a guarantee that you've been infected with the COVID virus. It may represent that you've been infected with some other virus that looks a little like it. And so we can't even say for sure that it means you've been infected. We certainly cannot say whether it means you're protected from being infected again. And that's one of the reasons that we are asking people to join the study and stay in the study, to be repeatedly tested and to let us look into their medical record so that we can start piecing that information together.
Okay. So I guess to follow up on that, you've gotten 1.5 million data points, and you are trying to put kind of the pieces of the puzzle together and look for correlations and see if there's any common points or what the differences are. Do you have a summary of maybe what you've learned so far from how long we've been part of the COVID study, the antibody study?
Yes, I think that we've actually got some really exciting information already. We are working on trying to figure out the very best way to present it in medical journals. So teams of statisticians and epidemiologists and virologists are looking at the data to make sure we don't overstate it or understate it. Mm-hmm. But I can say with some confidence that with 1.5 million data points, we can say that most of the people in our study have had very few or no symptoms. Now, we started it at the end of the flu season, and we've been doing it through the summer. So that's a time when we don't get a lot of colds and flus, but we've got very few people complain of cough and sore throat and those sorts of things.
Yeah.
And at that same time, we know that we started on April the 9th, about a month after the ACC tournament shut down, about a month after we said, "Oh my goodness, COVID is here."
Yep.
We got our first volunteers enrolled, and at that time, we had almost 0% of our volunteers had antibodies. So we can say with some confidence there was very little COVID here at that time. And over the last several months, we've seen that number steadily increase. So we've seen very few symptoms, but we've seen the antibody levels increase over time, which tells us that a lot of us are getting infected without knowing that we were around anybody with COVID, without having any symptoms, but we are getting infected nonetheless. And Justin, I want to jump ahead to the next question. Is that good news or is that bad news? And I'm going to say it's, I think it's both. The good news is it's fantastic that most of the people that in our study who have developed antibodies during the study have not had any symptoms, have not been hospitalized, have not had any problems. That's fantastic. The bad news is they did not know that they were infected. And so they could have been infecting others. And so really we want to look at that data and say, there's a lot of pressure on us to make sure we're socially distancing and wearing masks and doing everything we can to protect each other.
So I guess we're gonna start taking questions, and I'm gonna have you answer some of the questions we're getting in from the participants and the attendees of this town hall in just a second. But just as I wrap up the first part of the town hall, if you want to just reemphasize, why is it so important to have as representative as possible mirror of what the community looks like involved in the actual community partnership study? How does that help make the study more impactful and more more accurate for you possibly?
Well, Justin, that's a great question. So, as this research is about the whole community, the whole Winston-Salem, Forsyth County, Triad, Western North Carolina. And there are lots of different parts to that community. And we realize that as we look at different neighborhoods, different ethnic groups, that there's been variable about how many of us have gotten infected, when we got infected. We know that among our Latin and Hispanic populations, that they were especially hard hit early on. We know that our African American communities have been harder hit than the general community overall. Yeah. And we want to make sure that this data captures that and reflects it. Dr. Fauci, the lead in infectious disease doctor at NIH, has repeatedly said how much he wants to encourage African Americans and Latinx community members to participate in the vaccine studies that are taking place, because he wants to make sure that they are represented in this effort to protect us. But he's also said that he understands, and we understand, that there is a historic level of distrust in studies like vaccine studies. And so Dr. Fauci has said repeatedly, if we can't overcome that distrust to participate in the vaccine studies, then the next best thing is to participate in studies like this, where we at least make sure that we understand what's going on in every element of our community so that we can design the right interventions to protect all of us.
Yeah, so I think that's a great point you brought up about the vaccine study. I've seen a couple of notes come in referring to the vaccine study, and if you wouldn't mind just giving us a brief synopsis of the main difference between this COVID community partnership antibody study and the vaccine study. What's the main difference?
Yeah, sure thing, Justin. That's we definitely want to distinguish between the two. So everybody's probably heard of Operation Warp Speed. That's what the government is calling their really unprecedented effort to roll out these vaccine studies, these vaccine clinical trials very quickly. And we have to say we've never seen anything like it, to have this many clinical trials move this fast.
Sure.
And there are a series of studies going on nationally looking at different vaccines to see if they will protect us from getting COVID. And we are doing those here at Wake Forest as well. This study, the COVID-19 Community Research Partnership, is not about giving anybody a vaccine or giving anybody a medicine. It's not an intervention in that way at all. It's just about learning what's going on. Who of us is at risk?
Mm-hmm.
How many of us are getting infected? And what happens to us when we get infected? So there's nothing, we're not giving anything to anybody. We're not testing any new drug or any new vaccine. It's just telling each other what's going on.
Okay. So we're starting to get more questions in from the town hall attendees. So I'm going to transition more to these, Dr. Sanders. I'm going to put you on the spot here, and I want you to know the answers to every one of these questions. A couple of questions come in to follow up. If you could just remind us how many people approximately are in the study currently, and are these numbers meeting your needs or not?
Well, so right now at Wake Forest, we have just under 20,000 volunteers.
Okay.
We would like more. 20,000 tells us a lot, but what it doesn't fully describe is every aspect of the community. For instance, we have a lot of middle-aged white people like myself who are participating very fully. We don't have as many people from the Latinx community or the Hispanic community. We don't have as many people from the African American community. And we would like more to make sure that we really understand what's going on. We also have a lot of people from Forsyth County and Guilford County and Davidson and Davie County doing very well. We don't have as many people further west of us. We don't have as many from Yadkin County or Wilkes County or Stokes County, Rockingham County. And so we would really love to have more people from all over the region participating.
Okay. So another question from one of our attendees. Is the protocol published on ct.gov? And also, when you say, quote unquote, most people who were infected did not know it necessarily, do you have an approximate percentage of what you're talking about when you say most people?
Yeah, so the protocol is on clinicaltrials.gov. Even though this is not a trial, we're not doing an intervention. This is a reported study, so it can be found on clinicaltrials.gov. And in terms of what percentage, I would say that it's, while I didn't look at the data today to get an exact number, the vast majority of the people in our study, meaning like 95+% of our volunteers have had very minimal or no symptoms. And if you extrapolate that to the whole community, and you compare it to the viral testing that's reported out of the county and the state, then we can say that it's somewhere between 5 and 10, closer to 10 times the number of people who have symptoms and get a viral test. It's about 5 to 10 times that number of people who have very few or no symptoms and convert them to antibodies.
Okay. So we're getting a couple of questions in about the survey within the study, and then a couple of questions about the antibody, the actual blood sampling part as well. So I'll try and get to both. So we're getting some questions in around the definition of interaction. So in the daily survey, there's these interactions that we have to report. Did we come in, what kind of interactions do we have with other people? Does this mean people inside our quote unquote bubble, your immediate family you live with? Does it mean I was, 6 or 8 feet away from someone at a gas station, at the gas pump, or at the grocery store? Do I have to, am I counting those people? Can you help clarify that a little bit?
Yeah, Justin, first I have to apologize. We blew it on that question and have gotten lots of feedback about that. It takes us a while to correct when we get a question onto the Oracle database. Then it takes us a good while to be able to reprogram it and get it changed.
Okay.
That was one that we were not as clear as we should have been. What we had intended was, interaction outside your bubble. So we assume that, that you're probably not wearing a mask at home with your family. And that's totally fine. So this was intended of, did you interact with somebody within a close proximity, say within 6 feet, and for longer than 10 minutes outside of your normal family interactions?
Okay. So that's when you are maybe in some sort of measurable way, the potential risk exposure might be elevated when you're in those types of situations.
That's exactly right.
Okay. So for the blood sample, the portion of the study, can you clarify, you're not sending it to 100% of participants, and maybe help us understand the selection process or why you're being that selective, and just to make sure you're helping ensure that you're going to get a good diverse cross-section of your sample that you're bringing back into the lab, right?
That's right. And so thanks for asking for that clarification, because I think it's really important that everybody knows how we've approached this. And the first thing that we wanted to do was to make sure that we have good representation across the full spread of the community. So we pulled the census tract data for 20 counties where we have a good representation of Wake Forest patients. So we thought, that there was a good chance that we would have enough volunteers of Wake Forest patients for these 20 counties, which would be 20% of the counties in the state. We did the same thing with our partner south of us for Atrium.
Okay.
We pulled 20 counties for Atrium and looked at the census tract data and said, based on this census tract for this county, we need this number of 18 to 30-year-old white men, this number of 40 to 50-year-old African-American men,
Okay.
this number of 70-year-old Latino women, to fully represent what is going on in that geographic area. And we started off by saying, if you are a volunteer that meets one of those criteria, that meets one of those buckets, if you're the first 40-year-old African-American woman in that county, and we need 5 40-year-old African-American women, then we selected you. If you were number 6, maybe we did not, because we already had 5. Now then on top of that, that covered us geographically and demographically.
Mm-hmm.
And we have selected populations that we felt were either at higher risk to get infected, healthcare workers, or at higher risk to have bad outcomes. And so we're doing that across all of our partners. For us at Wake Forest, we started off with healthcare workers. And then as the epidemic grew and we realized, our African-American community and our Latin and Hispanic community are being especially hard hit, we started off oversampling healthcare workers, and then we began oversampling African Americans and Latin and Hispanic members too, so that you were more likely in those populations to be selected to make sure we were getting a good representation. And we are continuing that sort of move.
Okay. So another antibody result related question or two. So help us clarify the meaning of negative antibody tests versus positive antibody tests. Sometimes positive means good and sometimes negative means bad. In medical lab results, sometimes being able to analyze results of different lab medical tests can be challenging at times. So maybe walk us through that. And then also, you're measuring for two different types within the study, correct? Can you talk about that a little bit?
Yes, certainly. So first, when we say the test is positive, it means we detected an antibody. And when we say it's negative, it means we did not detect an antibody. Mm-hmm. So it doesn't mean positive good, negative bad. It just means positive, our test detects an antibody. Now, there is always the possibility that the test is detecting an antibody, but that's not really the right antibody, and that we would call that a false positive. And sometimes somebody really could have an antibody against the COVID virus, and our test not detect it. We would call that a false negative. We have tried to choose the best tests that we can within the logistical framework that we're operating under, which means that we're trying to do these tests at home, or at least do the collection at home, which means these are not the very best tests that could be run. They're the best tests that we can use and allow people to collect their antibodies at home. So we've tried to use the best ones possible to reduce the number of false positives and false negatives, but there are always going to be some. And then we're testing for two different types of antibodies.
Yes.
And there are, the human body makes at least five different types of antibodies. I say at least because I'm sure one of the scientists on the call is going to discover some more. But we make multiple different types of antibodies. They have different functions. Two of them that are commonly measured in clinical care are IgM and IgG, and those are the two that we're testing for. And IgM we tend to think of as the rapid antibody. It comes up usually very quickly. And when I say quickly, about a week or 2 weeks after we get infected with something, we will start to show detectable levels of IgM. Sometimes it will stay up, but often it comes up and it stays up for a few weeks or a few months, and then it goes away. We don't detect it anymore. And then there's another antibody, the IgG antibody, which tends to come up a little slower. It's like the immune system is working on the process longer to make sure that it's good. But then once it's good, it stays up. And so usually we see the IgM come up in a week or two, and the IgG, maybe it takes 2 to 6 weeks to come up. But then the IgM will go down after a few months, and the IgG should stay up at a higher detectable level for maybe the rest of your life.
Okay. So I'm going to keep going down this path. So let's say I have I test for an IgG. That might help clarify why maybe I get initially a positive result for the IgM, and then maybe two test samples later, it tests negative. That would help clarify maybe why that's happening.
Right. If somebody had a negative test and then it was a positive IgM, maybe positive, and then a negative, that is probably because they made an IgM, they were infected by the virus, their immune system made an IgM, and it lasted for a little while, and then it dropped below the level of detection on our test, which would be a normal phenomenon. Now, I've had a number of volunteers write me and say, my IgM came up, and I expected then the next month to have my IgG come up, and it didn't happen. Yeah. What's wrong? And my short answer is I don't know. But the longer answer, and I hope I've written this back every time when people have asked me, is that there are a couple of possibilities. And one is the test that we started off with, made by a company in California called Syntron. It turned out it just wasn't very good at finding IgG. It wasn't terrible, but it wasn't as good as we thought it was when we did the validation test. And so it may be that people made an IgM and a month later made an IgG, but the test we were using just wasn't good enough to pick up that IgG. The other possibility is that, and this is being reported by a number of studies around the world, that if somebody has few or no symptoms, they may not develop a very high level of antibodies. And,
Okay.
and they may not develop an IgG. They may, instead of their immune system preferentially making that long-lasting IgG, it may convert over and make a different type of antibody called IgA. And we're not testing for IgA right now. And if people ask, well, why aren't you? Well, it's just not on the test kits that we're able to use. And also because IgA is usually found in things like saliva.
Mhm.
And I say that as a sneak peek of things to come, because we are planning, starting very soon, to be sending out some tests for people who are reporting symptoms of fevers, chills, other problems, or whose antibody tests have suggested that they've gone from negative to positive, and then maybe just a few random. We're going to send out some tests where people will collect some saliva, some mucus swab, some oral mucosal swabs,
Mhm.
and send them back to us so that we can test for virus, and we will probably test for IgA in some of those as well.
Yeah, it'll be interesting to see what the symptom reporting trends, how they change or don't change, or how much they change as we get into cold and flu season. I had one person here, and this might be more of a PSA question than a technical study question, but someone said, should they still get their flu shot this year if they're participating in the study?
Absolutely. We desperately want you to get the flu shot for a variety of reasons. One, we just want you to be healthy. We want you to be well. Two, the more of us who get our flu shots, the less flu we're going to spread to each other, and the less confusion there's going to be about, is it flu or is it COVID? So I think it's more important than ever this year that we get the flu shot. I will say I know that you're getting hit with some questions about the vaccine studies that are taking place.
Yes.
And you can get the flu shot and get the COVID vaccine study if you volunteer for that. But we do want to space that out so that if you think you're going to volunteer for one of the COVID vaccine studies, please call us and ask us, when should I get the flu shot? Because we'd like it to be at least a month apart from when you get the COVID shot.
Okay. Yeah, we are getting some vaccine study related questions, and I know we want to focus on the COVID community partnership study, the antibody study for this town hall. We might set up another town hall for the vaccine study if there's enough interest, because we are getting some questions about that, which is great. It's very encouraging. I do have another question about the antibody study. Someone asked, is the sample kit that you use the mobile app for at home different from the sample sending in a blood sample? What's the difference between those two?
That is a great question, a very nuanced question. So, and it's going to be a two-part answer. So, up until recently, up until now, there was really not much difference. So some people got the kit that they pricked to their finger and put a drop of blood on what's called a lateral flow assay. It looks kind of like a home pregnancy test. And it would show a couple of bars, and they would take a picture with their phone, and they could just read it themselves, but somebody on the other end of the phone would also interpret it and send them back a message saying that's positive for IgM or IgG, or that's negative for antibodies, or you didn't do the test right. The other people got a test where you prick your finger and you take a couple of drops of blood and you collect it on a little Q-tip looking device called a Neoteryx Mitra device, and you would mail it back to us. So up until recently, we were taking the blood off that Neoteryx tip and running the exact same lateral flow test. So there was really no difference in the quality of the test. You either did it yourself at home or we did it in the research lab here. But the reason we were doing it that way was because we were going through the process with LabCorp, our partners at LabCorp, for them to validate one of their machine tests and to set up their automation so that those tips could go back to LabCorp and be tested there. Is that a better test than the at-home lateral flow assay? Some people think so. They're very close, but that may be a better test. It may be a little bit more reliable, and so we wanted to be able to set it up and see. And we're in discussions now with the CDC about should we continue to use both types of tests? Some people doing them at home and doing the home pregnancy type test at home, and some people sending blood back into LabCorp and having it done there. Or should we shift everybody over to a LabCorp test? Or should we shift everybody over to a do-it-yourself at-home test? And CDC is, well, these are hard questions. And so every week we have a meeting with CDC and we go back and forth. But we've got to make a decision very soon, and I expect by the next town hall, I think, Justin, I'm going to give you a clue. Ask me that again at the next town hall because I think by then, my answer is going to be they were exactly the same up until this point, and then we made a shift, and now we're doing one or the other, or there's this clear difference between the two now.
Okay. So someone else asked, what, based on your current data, and I know it's maybe evolved as you've gone along, what's the percentage of people in the study who are currently testing positive for the antibody?
Right. As I mentioned earlier, I'm laughing because as I mentioned earlier, we're really anxious to be publishing some of this data, but because of the way we collect it. The statisticians, the epidemiologists are constantly cautioning me not to use the wrong term, and so I want to be careful about how I'm phrasing this. When we started off in April, and we were doing the tests, if you looked at any day or any week, that first couple of days, that first couple of weeks we were doing the test, it was close to zero. We might have had a few positives, but when you calculated in the chances of false positives, it was close to zero. And then from April into May, it crept up to about from 0% to about 3 to 5%. And then from the end of May, where it was maybe about 5% until the end of June, we saw a big jump during that time. So we went from having 3 to 5% of the daily tests being positive at the end of May to having 8 to 12. Some days it was more like 12 to 15% were positive. When you smooth that out over, say, a week or two, it ended up in about the 8 to 10% range. But we put a graph on our website for a while that had a line going up to about 15% because we were counting it day to day, and that's the way the trend was going. Now, I'm not sure I can tell you 100% why, although I'm going to be happy to give some conjecture, some guesses here. But while that number really zoomed up over June, it started to level out and come down in July, and has continued to come down, flatten out, and we have not been able to do as many tests in August as we had wanted. We had logistical problems, and I'll answer that question in a second about why. But so we don't have as much data for August, but it was coming down in July and into August, and it really got down again to about that 8% range. And so why did it come down? Well, at the same time that the numbers were coming down, we could see more and more of us answering that, yes, I wore a mask. Yes, I wore a mask every day, most of the time. Can I absolutely swear that it was masks that were doing it? I can't say for 100%, but I can say that, boy, the more of us that marked, yes, I wore a mask, the fewer of us had positive tests. So I would be surprised if there's not a connection there.
Yeah, that's great information, Dr. Sanders. And we'll be wrapping up relatively soon, but we're going to keep going with a couple more questions. I do just want to point out Dr. Allison Matthews with the Maya Angelou Center for Health Equity. She put in the comments the URL, and I just want to verbalize that. It's wakehealth.edu/COVID-19 community study, or people can call 336-70-COVID, 336-70-COVID. If they're interested in participating or have more questions about the study, you can contact us through those two methods. Or if you have a more personal question about participating in the study or not, you can feel free to call that number as well, and they'll be glad to try and help. So I guess I want your analysis, Dr. Sanders, maybe, if you will. This is, being a part of research studies is not foreign to Wake Forest Baptist Health. I know research is one of the core pillars of the institution. In dealing with COVID and working through combating COVID-19, what is your take on maybe the difference in the heightened level of urgency or awareness? Obviously, it's in our media cycle so often. I guess give us maybe a at the end of the talk show, you have 90 seconds to kind of to be on a soapbox and talk about why it's so important for everyone to kind of rally together. And this is one way that people can rally together and help each other.
Well, certainly when we put out the call to action to say, hey, we need to come together and figure this out, none of us had any idea what was going to happen with COVID, how rapidly it would spread, how many of us would end up in the hospital, in the intensive care unit, or worse. As things have gone, we've learned more about the epidemic. But part of the way we've learned a lot more about the epidemic are by participating in research studies like the COVID-19 Community Research Partnership. And I see lots of questions that you've not had time to ask me pop up here on the screen. And I know lots of us have a lot more questions about what's going on with this infection. What are the long-term consequences of getting infected? We just don't know those things yet. And we're not going to know them unless we have lots of us come together and be willing to enter data, to let people go into our health record, to look at, gee, I've got high cholesterol. I got COVID. Am I more likely to have a heart attack or a stroke this year than somebody who had normal cholesterol? Those are the things that we really need to figure out about this infection. And then as vaccines become available, that's going to make it even more important that we figure out more about the infection and more about the vaccines. We can determine who needs the vaccines first and what strategy should we take to roll them out? And are there any risks with those vaccines in the short term and the long term? And it's these sorts of studies that are going to help us figure those out. So I really, really value what I'm outrageously proud and impressed to be a part of a community, to be a part of a group such as we see here in Winston-Salem and the Triad and Western North Carolina, with so many people who are willing to come together and contribute data and help each other learn more about how to deal with something that we've never dealt with before. So thank you all for being part of that.
That's great information, Dr. Sanders. We do have just a couple more questions as we get close to wrapping up. I'm going to try try and get as many in as possible because we've had great participation and engagement from the attendees. So if you could talk a little bit about, there's the study, the in the lab analysis going on, but through the community partnership portion of the study and trying to engage the community and working with the Maya Angelou Center for Health Equity, there's been some actual real good tangible benefit to the community, whether it's with the mobile clinic or the leadership council. Would you want to talk about that just for a second?
Yeah, Justin, I appreciate you pointing me that direction because I do want to thank so many leaders in our city, our region, so many community leaders who've come together, sharing of their time freely to say, these are the things that we need to do to get the message out better. These are the things that we need to do to help people know how important it is to be involved and to make it easier, to make it possible for them to be involved. So thank you for that leadership, all those people who have contributed so much. And then we've had volunteers out passing the word at economics programs and at community activities around churches, around parks to make sure that people are aware that they can participate. And then we have used many of the resources. We've used a lot of the resources. Well, I should say that the vast majority of the resources of the funding that's going to the study is to pay for the testing. But we have taken a chunk of the resources and have put it forward to the mobile health clinic, to getting the mobile health clinic out into neighborhoods that needed more medical care, and to make sure that they're getting the care, but also that they have a chance to be able to sign up for the study and help us know what's going on in their neighborhoods. We realize that some people don't have the electronic connection to be able to do the daily survey, and so we've worked with local partners at telephone services to try to find affordable alternatives for those people. We really appreciate all of that. And then we've got a lot of local businesses, whether it's been information about the study, printing presses or T-shirts or a variety of different local vendors who have helped us in putting the word out, and we really appreciate all that they've done for the study as well.
That's awesome. That's great information. And then this is a follow-up to one of your previous comments about being a Wake Forest Baptist patient. Now, if someone has, some people have multiple doctors or specialists for certain things, and they might have, this doctor's affiliated with this organization, this other specialist with this, maybe this specialist with Baptist. But as long as one of their doctors is Wake Forest Baptist Health, then they should be able to participate, correct?
Right. If they've ever seen any doctor at Wake Forest Baptist Health, they can participate. Now, some people have asked me, well, I get most of my care at Cone or at Novant. Am I still valuable? Yes, you're still valuable. It may be harder for us to get all the information from the electronic health record from Cone or Novant or some other site, but we're working on that. We are, we've just had so many people at Wake Forest in so many different areas trying to figure these things out, and our privacy people and contracts people are working with our friends and colleagues at Novant and Cone and other sites to try to figure out how to make sure we can share that data effectively.
That's a great lead in to one of my last questions here. Speaking of privacy, someone asked about privacy. So what happens to the data, my data that is collected as part of the research study? Does it go into some massive database that is sold? The analysts are used for some sort of profit, or how is that protected?
Justin, thank you, and thanks for the volunteer who asked that. First, we can say that the data is not going to be sold. There's no profit motive taking place here. And secondly, we can say that that no volunteer's personal identified data is going anywhere. Now, by being a volunteer, you've given me permission. You, Justin, have given me permission to specifically go into your record and make sure that I link your results to the right answer. That it's not just a random thing. But once I've done that, then I take Justin Gomez's name off of it completely to move that now de-identified data into other databases where we will combine your data with data collected by our partners Atrium Health in Charlotte, and Wake Med in Raleigh, and U Hanover in Wilmington, and the University of Maryland in Baltimore, and Georgetown in Washington, D.C., and University of Mississippi, and Tulane. So we have a Atlantic Coast, Mississippi Delta database that is collected, and we know how many Hispanic males and African American females, but we don't necessarily put anybody's specific identifier data into that big analysis pool.
Okay. That is, I'm sure, probably helpful to several people listening right now. As we wrap up, I do want to make people aware of the website again, wakehealth.edu/COVID-19 community study. And the phone number is 336-70-COVID. And I think someone mentioned that will these answers be available in Spanish? I will say that Dr. Melendez, one of your colleagues, and some other providers and community partners are going to be facilitating videos, and those will be posted on that website, the wakehealth.edu/COVID-19 community study. So Dr. Melendez will be addressing some of the frequently asked questions in Spanish as well for people to take advantage of watching that. So special shout out to the staff, Dr. Matthews, and everyone at the Maya Angelou Center for Health Equity for everything we're doing to help facilitate not only the town hall, but all the community efforts. And thank you to Dr. Sanders for joining us today. And it looks as though from the engagement we got, I hope to be doing another one of these town halls in the near future as well.
I hope so too, Justin. I really appreciate you and Allison Matthews and Mark Mistison and everybody who's worked so hard to put this together. And I hope that we can do this regularly. This was our first one, and we wanted to answer a lot of questions. But I promise as we do them more, we will also start sharing more data, putting up more graphs, and going through, because we've got a lot of smart people in the community. Not a day passes that I don't get an email with a really smart question about how we're doing the test or what the data mean.
Well, yeah, that's very appropriate. And Dr. Sanders, thank you once again. And I want to thank everyone that has joined for this town hall. Thank you so much for your participation and engagement. It really does mean a lot to us to have this community collaboration just to make the study as meaningful as possible. So we look forward to doing the next town hall at some point in the near future. And Dr. Sanders and everyone listening, I hope you all have a great evening.
Thank you, Justin. Thank you all.
See y'all later. Bye-bye.
Bye-bye.